Hello everyone, welcome back to our channel. I'm Dr. Ashmita. So today in this video, we shall continue with the morphology of chronic viral hepatitis. Before we understand the gross under morphology, before we understand the gross features of liver in chronic viral hepatitis, we will discuss about the microscopic features. This understanding of microscopic features in chronic viral hepatitis will help us to better understand why the gross changes has occurred. So let's study about the microscopic features of chronic viral hepatitis. Here in this image, so this is a classic hepatic lobule containing central vein in the center and these plates, pink color structures, these are the hepatocytes in a single strand, that is the hepatic plate. And to each corner of this hexagonal hepatic lobule are this portal triad. Portal triad consists of hepatic artery marked in red. This is the portal vein and this is a bile duct. And also we have a lymphatic channel to each corner. So this is a classic hexagonal hepatic lobule, central vein, hepatic plates, and the portal triad containing hepatic artery, portal vein, and bile ductule lymphatic channel. So, in this chronic viral hepatitis, this infected hepatocyte, this ongoing infection and ongoing inflammation of the hepatocytes within the classic lobule. These are the hepatic lobule. Within this lobule, the hepatocytes are getting infected because of which there's inflammation. Inflammation means because of this infection, the inflammatory cells has to be present. That is, the lymphocytes have to be recruited towards the site of infection. From where do these lymphocytes get recruited? From the circulation. Circulation means here portal tract contains this portal vein and hepatic artery. So these are the sources of lymphocytes. Therefore, there's a dense lymphocytic aggregate, lymphocytic infiltrate in and around the portal triad. So these blue dots are round, small round blue dots are the lymphocytes, and also plasma cells are recruited for production of antibodies. All these plasma cells with this except cells with eccentric nucleus, these are the plasma cells, and the small round blue dots are the lymphocytes. These inflammatory cells are recruited from this portal triad containing portal vein and hepatic artery. So there will be dense inflammatory infiltrate in and around the portal tract. That is called a portal tract inflammation. It is called a portal tract inflammation, which is the hallmark. It is a hallmark feature of chronic hepatitis. Portal tract inflammation is a hallmark feature of chronic hepatitis, and the severity is directly proportional to the activity of the disease. So so it is due to chronic immune response. This portal tract inflammation is due to chronic immune response against the viral antigens expressed. The viral antigens will be expressed by the infected hepatocytes. So immune response is given by this lymphocytes and the plasma cells, that is the mononuclear inflammatory infiltrate that will be recruited from the portal tract. Therefore, portal tract inflammation is present in chronic hepatitis, which is a hallmark feature. Here in this histopathology image, so this is a histopathology image showing you there's a portal tract. Actually, here's a portal tract containing this bile duct. Here, bile duct can be visualized with this epithelium, bile duct lined by epithelium. The portal vessels, this is a portal vein containing this endothelial cells. It is thin-walled, and the exact morphology of a portal tract containing the bile duct, portal vein, hepatic artery is not visualized because it is obscured by this dense lymphocytic infiltrate. This is small round blue dots. All these round blue dots are nothing but the lymphocytes. These are the lymphocytes. So there is dense lymphocytic infiltrate. There is dense lymphocytic infiltrate around in and around this portal tract, which is called a portal tract inflammation, which is a hallmark feature of chronic hepatitis. Here, this is other image showing you this is a portal tract area containing portal bile duct, portal vein, hepatic artery, but the exact morphology is obscured because of this inflammatory infiltrate. There's a dense inflammation, there's a dense lymphocytic infiltrate around the portal tract. This is called a portal tract inflammation. This is number one morphology in chronic hepatitis. Number two, there is interface hepatitis. Interface means from this portal tract, here we have discussed as a portal tract inflammation. Here coming here, this inflammation will spill over to the peripheral hepatocytes of the classic lobule. This is the classic lobule edge. From this portal tract, there is a spillover of this inflammatory cells. So the first cells to be affected are this peripheral hepatocytes. The peripheral hepatocytes of this classic lobule are the first one to be affected. And whenever this inflammatory cells will spill over the infected hepatocytes will be killed by them. That is, they undergo apoptosis and necrosis. Necrosis means this leak a cell membrane disintegrate, leaking the contents out. Apoptosis means it is contained. Cell death is contained, does not leak out. And here, the this necrosis and apoptosis occurs piece by piece. First, this outermost layer of hepatocytes get infected. Therefore, there will be disruption of the limiting plate. There will be disruption of limiting plate. Disruption of the limiting plate. What is a limiting plate? Limiting plate means to the extreme corner, the first peripheral set of hepatocytes of the hepatic lobule is this limiting plate. As soon as the inflammatory infiltrate, they come spill over the peripheral hepatocyte, the first cells, they undergo necrosis. So this limiting plate will be disrupted. Later, it will move further inside. It will move further inside and cause necrosis and apoptosis. Therefore, here necrosis and apoptosis are occurring layer by layer. That is one layer. Again, they move inside other layer, other layer. So it is occurring in piece. Chunks of hepatocytes are being affected. This is called a piecemeal necrosis. It is called piecemeal piecemeal necrosis. Piecemeal necrosis. Therefore, this interface hepatitis is also called piecemeal necrosis because the spilled over inflammatory cells will cause necrosis. The spilled over inflammatory cells will cause necrosis, apoptosis of the peripheral hepatocytes as chunks, piece by piece. It will move. First, it will affect the outermost, then again it will move inside, layer by layer, necrosis, apoptosis occurring. It is called a piecemeal necrosis. So this we can visualize, and because of this, because here the hepatocytes are disintegrating, it gives a moth-eaten appearance. It gives a moth-eaten appearance. Moth-eaten appearance means the disintegrated and necrosed hepatocytes will leave behind an empty space. Here, empty spaces will be left behind to the peripheral zone. Gives an appearance of moth-eaten, as if some rats have bitten it. It gives this empty spaces will appear as a moth-eaten appearance because of this interface hepatitis. So this image, histopathology image, you can see this is the portal zone, this lowermost zone is the portal triad. It is obscured because of this dense inflammation. Here you can see this is the classical lobule, that is the classic limiting plate. Here the inflammatory infiltrate, the lymphocytes, they are moving from the portal tract inside the classic lobule. So this is called interface hepatitis. This lymphocytic infiltrate present at the junction of portal triad and classic lobule. This is an interface hepatitis. Interface hepatitis. So after once it moves in, it causes necrosis layer by layer. This outermost, later this later. It is called a piecemeal necrosis. It is called piecemeal necrosis. This is about the interface hepatitis. Third entity is lobular inflammation. Lobular inflammation means inflammation occurring within the lobule. So, firstly, this individual hepatocytes, these are the hepatic plates, these strands are the hepatic plates. The individual hepatocytes, they undergo necrosis. Individual hepatocytes are affected. It will be affected. Scattered single hepatocytes will be affected. And there is a macrophage response because of this infection. The macrophages of the liver, that is the Kupffer cells in the sinusoids. These are the Kupffer cells. Cover cells in the sinusoid, they increase in number. As an immune response, these macrophages will increase in number. So there is cover cell hyperplasia. There is cover cell hyperplasia. And thirdly, there is a focal inflammatory infiltrate around the central vein. This is the central vein. Around the central vein, there is a focal areas show inflammatory infiltrate. This indicates there is ongoing inflammation occurring within the lobule. This is called a lobular inflammation. This is called a lobular inflammation. This we can correlate here. This is the histopathology image. So this is within the lobule containing hepatocytes. These are the individual hepatocytes. In between the hepatocytes, you find the small round blue dots. Small round blue dots. So in between these hepatocytes, you find a small round blue dot. So inflammation is present within the lobule. This is called a lobular inflammation. It is a lobular inflammation. Next, there will be bridging fibrosis, bridging necrosis and fibrosis. See this necrosis, this individual hepatocytes, they are getting affected. And now this necrosis will get, it will, more cells will get affected. So a group of cells getting affected. A group of cells now get affected in a row. Continuously cells get affected. So it is called a confluent necrosis. I have discussed in acute viral hepatitis. Confluent necrosis is a cluster of cells undergoing necrosis. So a large cluster will become a bridging necrosis. So as firstly, a cluster of hepatocytes undergo necrosis. This confluent necrosis, it is called a confluent necrosis. Now which progress further and our entire strand will undergo necrosis. This is called a bridging necrosis. Bridging means it connects two vital structures. For example, a strand of hepatocytes running from this portal tract to central vein. So it is called a portal central bridging necrosis, portal central bridging necrosis, or a portal bridging necrosis from this one portal tract to other, a set of hepatocytes here. It is called a portal bridging necrosis. After necrosis, it is followed by deposition of collagen. Here, between this vascular sinusoid, this is the vascular sinusoid containing macrophages, and these are the hepatic strand. Between these two, the space is called space of Bisi. The space of Bisi contain ito cells. They contain the ito cells or the stellate cells which act as myofibroblasts under the condition of inflammation. So these ito cells, they lay down collagen. Wherever necrosis has occurred, they lay down the collagen. So a set of hepatocytes undergone necrosis here, like a bridging necrosis, which will be followed by bridging fibrosis. It is now followed by bridging fibrosis. Bridging fibrosis. So there's a bridging necrosis followed by bridging fibrosis. And here we can correlate. This is a Mason trichome stain. This is a Mason trichrome stain which will usually stain the collagen fibers in blue color. So here this blue color, these are the collagen bundles. So there are collagen bundles here. These are the bridging fibrosis. And in between the bridging fibrosis, fibrous strands, you can visualize certain nodules are formed. Nodules of regenerating hepatocytes. So the hepatocytes now they attempt to regenerate. So they increase in size and they are trapped by this collagen bands. This is called a regenerating nodule. It is called a regenerating nodule surrounded by the bridging fibrous bands. So because of this and the surrounding collagen bands will restrict the regenerating nodules. It will restrict the regenerating nodules. Here we can see correlate here. Now entirely all these regenerating nodules will be present. Fibrous deposition occurs here. It will form a like bridging fibrosis occurs, and in between the cells will attempt to regenerate. After necrosis, they'll attempt to regenerate. So it forms a regenerative nodule. But this nodule will be cut off from the blood supply because of dense fibrous restriction. The blood supply to this hepatocytes, regenerating hepatocytes will be cut off, because of which again all these cells will collapse further. Eventually they'll collapse because of lack of blood supply. Therefore, there will be a collapse of all this regenerating nodules and the hepatocytes and the bridging fibrosis. All this will collapse and the entire lobule will be disrupted. The lobular architecture will be distorted because of this bridging fibrosis, collapse of bridging fibrosis. So we have discussed this is the bridging fibrosis and regenerative nodule. Ultimately, they'll collapse because of lack of blood supply and the entire lobular architecture will be distorted. Coming to individual hepatocyte changes. Individual hepatocyte changes we have discussed in detail in acute viral hepatitis also. Let's revise again. There will be ballooning degeneration. Ballooning. So this is a ballooned hepatocyte. What is ballooned hepatocyte? A normal hepatocyte is roughly polygonal, it is like small and it has central round nucleus, the eosinophilic cytoplasm, and they contain a sodium potassium pump. Because of infection and inflammation, the sodium potassium pump failure occurs, because of which the sodium will retain inside. Along with it, water also retains. Sodium water retention causes this hepatocyte to blow up, to swell up, and nucleus will be disrupted, it will be displaced, and this cytoplasm will become pale. This is called a ballooning degeneration. Here you can see this is the hepatocyte. For example, if this is a normal hepatocyte, this is a ballooned up hepatocyte with edematous cytoplasm, with the edematous cytoplasm. This is called ballooning degeneration. And there are apoptotic bodies. These are the apoptotic body. We studied that hepatocytes undergo apoptosis. It will become small, dense, cytoplasm becomes dense with a small pycnotic nucleus. These are called the councilman bodies. These are called the councilman bodies. These are the councilman bodies. Also, these droplets, these empty spaces, these are nothing but the droplets of lipid and glycogen. These are lipid glycogen droplets. Because of this inflammation, the hepatocytes will be impaired. So, glycogen metabolism, lipid metabolism are impaired. They are stored as vacuoles. These vacuoles within the hepatocytes. This is one hepatocyte, the cytoplasm pushed to the periphery, nucleus pushed to the periphery. Center we have a large droplet of lipid or glycogen. This is called a hydropic change. This is called a hydropic change. So we have studied the ballooning degeneration, councilman bodies, and the hydropic change here. And particularly in hepatitis B, chronic hepatitis B, in chronic hepatitis B, the hepatitis B surface antigen gets accumulated in the cytoplasm of hepatocytes. So when it gets accumulated in the cytoplasm, for example, it gets accumulated. The cytoplasm is filled with hepatitis B surface antigen. It gives a ground glass appearance. So the entire cytoplasm of this hepatocyte filled with this hepatitis B surface antigen, giving it a ground glass appearance. That's because of hepatitis B in chronic hepatitis B. So here again you can see. So this is cell with this cytoplasm giving a ground glass opacity. This is ground glass opacities, and also there is binucleation because the hepatocytes they attempt to regenerate. This binucleation. So the binucleation will indicate attempt of regeneration by the hepatocytes. And here particularly this is hepatitis C. In hepatitis C, there is like fat metabolism will be disrupted. So the lipid vacuoles can be seen inside the hepatocytes. It is seen as macrovesicular steatohepatitis. Steato means fat hepatitis. So macrovesicles, large vesicles of steato means fat hepatitis. In chronic hepatitis C, we can visualize this. And also, in this image, I have said about the ground glass opacity. But in few other cases, there will be presence of nuclei, sanded nuclei because of presence of hepatitis B core antigen. core antigen will get deposited in the nucleus of infected hepatocyte of hepatitis B in chronic hepatitis B. Standard nuclei means the nucleus might appear, it will appear like powdery. Here in this slide, we are unable to point out the standard nuclei. Few of the slides show the standard nuclei which is due to hepatitis B core antigen deposition. The ground glass opacity is because of surface antigen in the cytoplasm. So this is about the microscopic features of chronic hepatitis B. When we have to correlate with the gross findings of this chronic hepatitis B is further, it can be classified as early change, moderate changes, and advanced stages. In early stages, the liver is slightly enlarged, and it is slightly enlarged because of hepatocyte hepatocellular swelling. In the early inflammation, this hepatocellular swelling, I have said ballooning degeneration, because of which this slight hepatomegaly it manifests as slight enlargement. And there is fat metabolism defect. So fat accumulation occurs. Fat accumulation occurs. Fat accumulation means fat is soft, so liver also becomes soft and it gives a yellow tinge to the liver. And also there is mild inflammation. Because of mild inflammation, there is vascular congestion. Vascular congestion of the sinusoids will give you a red-brown color. So in the early stages, because of hepatocellular swelling, because of this ballooning degeneration, there will be slight hepatomegaly. So this slight liver enlargement. Also, there will be fat accumulation, which appears as a soft, which gives a soft texture to the liver and yellow tinge, and vascular congestion. Because of mild inflammation, is vascular congestion that gives the yellow, red-brown color to the liver. In moderate, again progressing to the next stage, in moderate stages, the capsule becomes tense. Why capsule becomes tense? With further enlargement. So in moderate, there will be progressive fibrosis. Necrosis, I have explained about necrosis, bridging necrosis, followed by bridging fibrosis. So there will be progressive fibrosis accompanied with regenerating nodules. So the liver on the whole, it expands, and this regenerating nodules means the liver parenchyma will bulge out. In moderate stage, it will bulge out. So the capsule, it becomes tense because of even further enlargement of the liver. The Gleason's capsule surrounding the liver, it becomes tense because of stretching. It gets stretched and it appears tense. It appears tense, shiny on external surface, and the edges become round. For example, this is a chronic normal liver. It has sharp edges. It has these sharp edges. In moderate changes, because of enlargement, the edges will become round. It becomes round. Usually, it is like this. And now, in chronic moderate stages, it appears the edges become round and it becomes firm because of fibrosis. Fibrous tissue is firm. So fibrosis means the liver becomes firm. And in advanced stages, like further, this regenerative nodules and progressive fibrosis, because of this lack of blood supply to the regenerating hepatocytes, because they're constricted around these boundaries of this progressive fibrosis, bridging fibrosis, the blood supply is cut off. Eventually, they will die. All these hepatocytes will collapse. Bridging fibrosis will collapse. That means the entire lobular architecture distorted. Now the liver becomes shrunk because of the collapse. Now the liver will be shrunk. It will shrink in size. It will appear as shrunken. And it is firm because of extensive fibrosis. Extensive fibrosis means it is firm. And nodules are present. The regenerating nodules, it gives a nodular appearance onto the external surface. So this is about the gross appearance that we have correlated with the microscopy. So here this is healthy liver. Usually, because if it is less than 6 months acute hepatitis and it resolves, it recovers. If it lasts for more than 6 months, the chronic hepatitis, the stages we have slightly enlarged, yellowish to red brown. Further enlargement will stretch the capsule, which becomes tense. It appears tense and shiny, and the edges become rounded now, and the firmness because of fibrosis. In advanced stages, liver will get shrink. It will shrink. It appears shrunken because of collapse of bridging fibrosis. And the regenerating nodules, the dots are the regenerating nodules. Regenerating nodules appear. So this is about the gross features of liver in chronic viral hepatitis. In our next video, we'll continue with the grading system, clinical features, and lab investigations. So if you like this video, please like, share, and subscribe to our channel. Thank you.